Hello to everyone, I'm Carlo. I'm very happy to be here. And I'd like to thank Claudio and Dr. Kakkar for inviting me uh, today to share my daily practice. Today we'll talk about the use of osteotome in atrophic maxillar rehabilitation. I'm going to show to you some cases I performed with the osteotome that helped me in getting a better result respect the drilling protocol. I know that we do not have a lot of time, but I hope I will be able to transfer to you interesting information. Before we start, I'd like to introduce myself. I'm Carlo Cacciamani. Hello to everyone another time, and thank you for spending your time with me today. I graduated in 2003, and from that moment, I improved my skills in oral surgery, taking part in a lot of courses and masters all around the world. In particular, I focused my attention in atrophic maxillary rehabilitation, and 4 years ago I founded a study group about the sinus crestal lift. Those are the other component of the group. All of them are well known in Italy and in Europe. They have a long-term experience in oral surgery. A couple of them have been in India as speaker for international groups and companies. The target of our group is to develop in sinus crestal lift using the evolution in summer technique, like tree-fine technique described for Dotton Fugazzotto and magnetodynamic technology. We started from the literature. We studied all the literature present until today, everything about sinus lift, and matched with our clinical experience that is done from 100 cases. From this were born new technique, consideration, and protocols that will help dentists during the lifting procedures. The target of our job is to give the opportunity to achieve a predictable result in every hands, from the unskilled young general dentist to expert surgeon. Moreover, everyone will be able to distinguish favorable site from non-favorable one and choose the best implant to place or when use bone graft. This is possible because we started to see the sinus from a biological point of view, thanks to Claudio Stacchi papers, who first talked about osteogenetic potentials of sinus. But what does it mean? Osteogenetic potential is the sinus capacity in making new bone from cloth. But where does the cloth come from? It comes from the skeletonization of membrane from the sinus wall and floor, in particular from the palatal and buccal wall. So, when we deal a wide sinus, those walls will be very far from the site where we are performing the sinus lift. So, elevating membrana will be impossible, almost impossible, or very difficult. Instead, a narrow sinus where it will be really easier. So we can resume that the capacity to create new bone depends from the anatomy of the sinus in which you are going to place the implant. Narrow sinus had a better result in terms of new bone formation than a wide sinus. It means that we have to approach different sites with different techniques. So we made a combination of techniques applicable in each situation and resumed them in schemes. This is the first scheme of three. We still have only the Italian version. We are working on the English one. It shows to do what to do in intercalate or distal monodentulism rehabilitation, in wide or narrow sinus. Another parameter we have to consider, of course, is the residual crest height. Of course, This is an example of protocols in case we have a very low residual crest, about 2 millimeters, in wide sinus in distal edentulism. The indication in this situation is the lateral approach, in accordance with the literature present until today. But there is a technique, not for all, that can help you in perform a sinus crestal lift. It's called killer mode. It consists in using a wide osteotome with concave or flap tip, direct to the bone crest. The beating must be very gentle to avoid the membrane perforation. This is the second scheme of three. It's little more complex and needs a legenda to be understood. It shows two implants rehabilitation in distal edentulism in case we deal different residual crest height situation in mesial or distal side. In, in this specific case, we have a residual crest of 3 to 5 millimeters in mesial implant site, signed with A, with narrow sinus, and residual crest of 2 millimeters in distal implant site with large sinus, pointed with B. The approach are different, but the procedures must be performed in simultaneous way to reduce the risk of Snyder membrane perforation. I will stop here my introduction, hoping to have left in you a little curiosity about the argument. And now let's talk about the topic of our discussion, the atrophic maxillary rehabilitation. In my practice, I often meet a situation like this, with low and thin crest in posterior area and sometimes in anterior area. In those cases, you can't think ordinary. You do not have enough bone to restore this arch. For this reason, during last 13 years, have appeared a lot of techniques, from lateral sinus lift to crestal sinus lift, from pterygoid implants to zygomatic implants, from transsinus to transnasal implants, or the last one, the Juxta implants. Every of those procedures are well described in literature, but I'm not an enthusiast about the zygomatic implants, for example, placed from general dentists. I prefer to have a skilled and more specific surgeon. Talking about osteotome, we cannot start without introducing, for one who don't know, those three papers from year 1994. The author is Robert Summer, who described for first the osteotome technique, that consists in a new method of placing implant in maxillary bone without drilling. Until that moment, osteotomes were used only in orthopedic surgery. This technique is the basis of our work and has undergone a series of evolution over the year. But what advantage can we have using this technique, and when can we use it? Basically, we have a good visibility thanks to a thinner instrument. The osteotome, if we compare to the implant handpiece, it is a big. No overeating because there is no friction, so no risk of osteonecrosis. Good handling respect to the bigger handpiece. In addition, drill-free technique preserve bone and permit to a bone condensation. When you deal a mesh class, for example, 3 on 4, this will increase the bone quality. As you know, the drilling technique is a subtractive technique. That means that we lose bone during the implant site preparation. And we have deal soft bone mesh class 3-4, we hardly find a good first ability. Instead, the osteotome technique not only preserve all the bone during the osteotome progression on bone, it condensated the medullary bone in the lateral side aspect. Starting from the thinner cylindric osteotome to the wider one, you can go from a D3 or D4 bone to a D2 or better. It will help you in finding the better for stability and preserve the buccal bone, avoiding the spires exposure. You can also use it in a split crest technique, but is a more skilled technique. Moreover, this article shows how the implant site prepared with osteotome has a better quality and quantity in terms of osteocytes present inside. This means that the implant you placed have a better second stability with an harder and more represented bone. Respect the implant placed in a site prepared with classic drills. Osteotome also permit to shape your bone ridge, expand the thin ridge to place implant. How you can see in the picture in the angle at the right, thanks to the collagen inside the bone and its elastic behavior and characteristic, it's possible to shape the bone and move it buccally. In a case like this one, how can you think you can place an implant without losing buccal bone? I did it simply pushing with osteotome buccally, going from the thinner one to the wider osteotome. But at the end, the most important application of osteotome, in my opinion, is the bone extraction. In fact, it can be used to fracture the cortical sinus floor, keeping the Schneider membrane safe. It requires good skills, of course, but is a very useful weapon to place implant in atrophic maxilla. There are several different techniques to do this, but basically, beating the sinus floor, there is a plastic deformation of the cortical bone before its fracture. It consequently moves the Schneider membrane apically into the sinus, making a space between the floor and membrane. This space will be filled by the cloth or the bone chip. It depends from the characteristics of the site. Do you know when you have to use the bone chip or not? It depends by the osteogenetic potential, as I said before. In narrow sinus, I generally use collagen sponge, while in wide sinus, I use bone chips. This is why, because in wide sinus we do not have a very good potential, so we do not have blood that create new bone. So we have to maintain a first stability done by the presence of bone chips. So you have a mechanical stability. You will never have biological or limited biological stability. You know, in the last 13 years, there appeared a lot of new techniques. There are developments from the original technique. All of them work fine, but they take generally more time respect the classic technique and can't be used in all the situation. Here you can see the MIS technique or smart lift technique from Dr. Trombelli, fluidodynamic technique or balloon technique, the Versa Barnes that works very fine, but you can't use it in 2 millimeters of height crest. I tried all of them, but the only one that gives me a predictable result is this one. This is my choice. the magnetodynamic technology. Basically, it is a device that applies a force to a series of tips mounted on a handpiece. The application of this force on the handpiece creates a movement of the tip on its axis that has always the same excursion, that is not more than 1.1 millimeters. This means that the excursion of the tip is always controlled and make the surgery safe because avoid the Snyder membrane perforation. Moreover, it expresses a great strength in a short time. Respect the manual osteotomy that do it in a different way because express a low strength in a long time. This case often BPPV, that is a very uncomfortable syndrome for the patients. The magnetodynamic technology uh, can express the spreading of the force consequence of the beating in around the 3 millimeters around the point of the beating point. This means that the forces will never spread on the cranium bone to the medial hairs, causing the BPPV. So we can consider the magnetodynamic technology absolutely safe for the patients, and you will have for sure a better outcome. But let's see something more interesting. Those are the application of the technique. We will see now some cases and we will discuss about them. All of the cases are performed with the magnetodynamic technology, in particular magnetic mallet. Let's start for the first one, the palatal approach. Palatal approach is a technique that gives us the opportunity to place implant in a safe way in case we deal a thin crest, and the target is avoiding the ridge bone exposure in the buccal aspect. Of course, we do it also to do not make a second surgery like the ridge bone augmentation. So that's the simpler way to rehabilitate a thin crest. It consists in place implant palatally, more palatally respect the center of the crest. In this way, I repeat, we will keep the buccal bone safe. This will avoid the implant spar exposure and will have a better long-time result in terms of implant success. If implant spires can't be covered by the bone in palatal aspect is not a problem because the thick periosteum can cover them, stabilizing and protecting them from the external contamination. Moreover, you have the opportunity to apply a bone graft there, and the palatal periosteum will help you in keeping it in place. This patient is a middle-aged Latin woman who was implanted for an overdental supported by 4 implants. For a personal and economical reasons, she chose to delay the finance prosthesis. It is a very old case, and at the time I was young and I feel very confident with my skills. So I just used the bidimensional X-ray to plan the surgery. I was pretty sure that the bone crest should be good in height and width. Soft tissue showed me a white crest, so I was relaxed, but it was just a supposition. I made the first surgery to extract all the teeth and to make a socket preservation on site 2.3. I apply the bone graft and my membrane, my collagen membrane, and then I suture it. When the second surgery, the day of second surgery came, my original plan didn't change. I just moved palated the implant position and took my mallet kit. The crest was enough wide to place an implant and maintain a thin layer of bone buccal. So the literature came to my aid and suggested me to a very good technique named palatal approach, the one I just described. This technique so consists in place the implant in a palatal position. The first approach of the osteotome, if you want to place a drill feed preparation, must be at 45 degrees palatally respect the long axis of the crest. And when we go through the bone, we move it buccally, finding the final position. This technique keeps enough buccal bone to avoid the resorption of implant spiral fenestration. Some palatal spirals will remain out of bone crest, but it is not a problem because the palatal periosteum, as just said, is very tight and is a very good barrier in bone augmentation if necessary. In a non-pathologic condition, there will never be an implant spiral exposure. The procedure in this case is completely drift-free because I want to increase bone quality and preserve the hard tissue. My only recommendation is to proceed with light movement, beating the tip gently. So enter palatal at 45 degree. Go on until you feel the buccal plate from the internal part of the residual crest, and then when you feel the plate is the moment we have to move the osteotome along the long axis of the crest, so vertical, perpendicular to the crest, and then you can place the implant. It's important to do this moment and this thing. Post-surgery panoramic show outright placement and light sinus crest elevation inside 2.5. The control at full months show that everything is okay. We maintained the buccal bone and performed good sinus elevation. There is bone also in the palatal aspect thanks to the little GBR we made. Do you think there is another way to solve this situation without GBR? Or better, do you think there is an easier way to solve the situation? I don't think so. Next case, talk about sinus lift. That is my daily surgery. So let's see something together. This case is a very old case where I need to rehabilitate a posterior maxilla in quadrant 1. The plan is to extract tooth number 1.5 and place implant inside 1.5, 1.6 and 1.7. This is a triple crestal sinus lift. It's a very challenging because few bone is present to stabilize the implant. I use three type of techniques. A killer mode technique to approach the 2 millimeters of residual bone. We talked about it a few minutes ago. A lateral management of sinus floor, a technique described from Scipioni that consists in place our osteotome perpendicular to the sinus floor, not to the residual crest. It must be at 90 degree Perform your crestal lift and then move the osteotome perpendicular to the crest. So it will permit to have elevation of the floor in a safer way because you're working with the plate of the tip, and then you have just shape your bone, move the osteotome, and performing another time the elevation. In premolar area, I used a special osteotome named Black Ruby that has a rounded tip to penetrate the bone easier. While in the molar area, I used a flat osteotome, was used to distract a thin bone plate into the sinus. Mallet has a lot of different kits with lot of different osteotome that must be used in different situations. The X-ray after 3 months show a good result in terms of bone gain that is confirmed by 1 year later casual control. There is no bone loss and a perfect new bone formation. I used an 8 millimeter implant that is a not short implant, but is the shorter one considering a normal implant. And that is the must used implant in my experience in sinus lift surgery. Just because I won't use the, is it possible, the shorter implant I can. This is another case. It's very old too. I do not use this implant connection today. I'm moving to conomorphs to obtain a microbiological seal and a deeper connection to manage the static. Anyways, in this case, I need to rehabilitate posterior atrophic maxilla in quadrant 1 and 2. The plan is to place 2 implants in position 1.5 and 1.7 and 2.4 and 2.6 after 2.4 extraction. Residual crest in distal implant is very low, like the previous case. The indication is the lateral approach because 2 millimeter is a very challenging situation. The indication should be lateral approach. Also in this case, I used the black ruby osteotome for magnetic mallet. I remember to you, it has a rounded tip that permit me to have a better bone penetration. I progressively increased the osteotome diameter to shape the bone and add bone graft. The bone graft I use is the xenograph plus fibrin glue, obviously in place where I suppose the osteogenetic potential, so the capacity to create new bone was not good. It generally happens in white sinus. I always place a little piece of collagen sponge within the bone and osteotome to have a soft bit. It will reduce the risk of membrane perforation. Every time I change the osteotome of the tip, I place another little piece of collagen sponge. As you can see, I move the osteotome in the palatal with palatal inclination, buccal inclination, because I want to be sure to elevate the sinus floor in all the aspects. The result is very good in quadrant 1, where you can check how the bone is increased, thanks to the correct management of the site. It is interesting to notice that the new bone formation starts from the basis of the site, instead the apical space, where you still find the graft or immature bone or osteoid bone. This is because the blood come from the lateral wall of the sinus and make a gentle vascularization of the graft starting from the bottom. Inside 1.4, I do not use any bone graft because I suppose that the site has a great osteogenetic potential. The space made by the implant will keep the membrane height and the cloth will create new bone. You just need some time. In second quadrant, we have the same result. As you can see, I always use short implant when I perform the sinus lift. This is because in literature, short implants are validated and they have a survival rate similar to longer one. So why make either sinus lift with the risk of no bone formation and membrane perforation? Remember, sometimes less is more. So the next case, we'll talk about pterygo implants that today represent the gold standard in fund arch rehabilitation. Pterygo implants for me are very useful because permit me to expand member rehabilitation in atrophic maxilla, and honestly, I love them. Not a lot of dentists know that from recent literature come that pterygo implants have a comparable or better survival rate respect to normal implants. Always remember this thing. And not all pterygo implants pass through the pyramidal process. What does it mean? The area of the posterior edentulous maxilla can be classified in two groups depending from the position of the maxillary sinus in relation to the available bone of the tuberosity where a pterygoid implant will be placed. It means that we will have the high PTG on the left, you can see on the left, that permit a more vertical placement going through the tuberosity and reaching pterygoid plates, but not passing through the pyramidal process. And the low PTG in the right, requiring placement angled posteriorly, which passes from tuberosity pyramidal process and finally reaching the pterygoid plates. So, in case we can't go through the pyramidal process, we will have a little lack of force stability. How can we compensate it? How to improve force stability in that situation? The drift preparation, is the way. As I said before, the drift preparation permits to increase bone quality. But another great advantage is the possibility to run very close to the distal limit of the sinus. And as you can see in this video, correct the insertion during the maneuver. The first osteotome has an active tip. It will permit to perforate the pterygoid laminae. Someone prefer to perforate it with drills. Someone prefer to perforate it with lamina, with this type of tip. This is the kit available in PT1, the pterygoid from OsseoTouch. There is everything you need from drills to penetrate the pterygo plate to different type of osteotome. Cylindric and conical osteotome, always with active tip. This case was performed with a full guide surgery for what concerned the four anterior implants, while pterygoid implants have been placed with an hybrid preparation. This means that I used the cylindric osteotome in guided surgery to create a safe way and then can be finalized with drills, osteotome, or everything you want. This was possible thanks to PT1, the pterygoid kit from ASOTouch, the one I've just presented a few moments ago. In this case, pterygoid implants are used to increase the prosthetic arch. I may do not place them maintaining for entire implants, but if literature tell me that this type of implants works better than classic one, why do not take advantage from the knowledge? Two surgical guides were built, one for the anterior implants and the other one for the pterygoid implants. Both guides were built with only 3 pins to stabilize it. Actually, in my experience, two more are necessary, and they must be placed as distally as possible. In fact, when the mallet beats the tip, it hurts the sleeves and consequently the guide. It can move the guide, and the ostotom can slip into the bone in a wrong way. So adding two more pins in the second molar area will make the surgery safer. There is a short part of the video that is generally longer that I want to show you. As you can see, I fixed the second guide. I placed the pins. The second guide is very in place. Is stabilized by the pins, and now go with the osteton with the tip of PT1, the cylindric one. I'm just so close to the plates, but they are really strong. So in plan, I I prefer to use the drills to perforate the plate. But this type of surgery, this first procedure, permit me to have a line to follow in a very easy way. So I enter with the drill, I perforate the plates, I check, of course, with the probe, and then I go with the black ruby, the black ruby number 2, to condensate the medullary bone. And last thing to do is place implant. It's very easy. You will have the correct angulation. This is another case. He's a very nice person. This case is quite simple and performed in the same way as the previous one. The control after 8 months show a perfect aesthetic and functional integration. The patient is very happy and the rehabilitation is very good. Now let's talk about transnasal implants that are really similar to pterygoid implants. And I love them too. Nasal implants have appeared recently in neurosurgery, but already have a good success. The reason why they are so appreciated depends from the height for stability they achieve and the strategic position they have. First, we need to elevate a flap that must be wide and uncover the limits of the canine pillar. Distally, we can see the sinus and medially the bone. To have a better mobility of the flap, sometimes it's necessary to cut the fibers above the nasal spine. But this thing must be done in a gently way. Marker with a pencil can be really useful. The second step is the elevation of the nose membrane, but it's important to move it only where we need. on the basis going laterally until the turbinating section where there is a stop that we feel in a clear way. The drills, this is the first that we use, must run on the bone palatally to keep a out bone buccally and to have, of course, a better emergence. Once the drill runs through the nasal floor, it's important to keep it in a buccal inclination, very close to the buccal plate. Now, it must go until the frontal process of the maxilla, where there will be a knot thrombone. The position of the process is showed on the picture. From that video, it's easy to see how the drill runs through the bone without perforating it. Don't worry if it happens. The implant spire can be exposed because they are protected by a tight thickness of soft tissue. In that position, the tissue is very tight. You are in free mucosa, free gingiva. Every time, check with a long probe if there is bone buccally and at the end of the site. And of course, you can check the length of the preparation. Next step is the pterigo tip present on PT1 that runs on the site, expanding it. Also in this case, it's clear where the tip way through the bone. It will stop in the same point where the drill ended. It's nice. You can see how it expands the bone. It's a very hard bone. It's difficult to remove it. Another time, recheck the site with probe, confirm everything. And next step is it's time to use my preferred tip, the black ruby number 2, to expand and shape the bone. This is the last instrument will be used during this preparation. It goes through the bone, it expands the bone, almost crack the bone. Really is the maximum expandation you can do. There is a very strong bone. Probably in this case, we should need a longer tip. I will talk with offset touch to create it. The last thing to do is to place the implant. It can be done manually or with a motor. I generally start with the motor until I reach a 50 Newton torque insertion, and then I proceed with manual motor. The movement must be of screwing and unscrewing to reduce the friction and the risk of bone fracture. Screw and unscrew, screw and unscrew. Okay. Now the implant is in place. There is no bone perforation and a perfect palatal emergence. Emergence. I'd like to show more cases. I have thousands of photos to share, but we have no more time. So let's talk about the last technique, the split crest. This very, this is a very challenging case because I found a very thin crest in this old woman. The plan is to place implant to rehabilitate the dental spaces in quadrant 1 and 2. Split cut was the only possible technique. It permits to increase the width bone and place implant. In this case, I also would like to make an horizontal GBR, so I chose a very nice technique described from Professor Trombelli in Ferrara. The acronym is SPAL, that means Subperiosteum Augmented Layer, but actually is the name of soccer club in Ferrara, where the Professor Trombelli was born and lived. Once you feel good, you can place implant. Sometimes happens that during the bone splitting, you need to perform a crescent sinus lift. Don't be afraid, osteotome can do it in the same time. For first, I use an osteotome of magnetic mallet to create an osteotomy in the middle of the crest. You know that split crest can be performed only with a minimum of 4 mm width. The osteotome must run until the implant length. Please be carefully because this is a very dangerous moment. You can fracture or perforate the bone. If you feel more confident, you can also use bores and piezo surgery tips. In this case, I don't need relief cut because I was confident with my skills. One time I've done this, I will use osteotome from the thinner to the bigger one. I use them gently until the implant length. During the running, push gently the osteotome buccally to shape the bone crest. This is a deformation, controlled deformation. Once you feel good, you can place the implants. Now it's time to increase the reach, so I can apply the SPA technique, the SPAL technique needed. SPL technique is a surgical requires a surgical buccal access at the time of implant placement. First consisted of a split thickness flap to raise the most superficial mucosal layer, followed by elevation of the periostal layer, which was detached from the buccal cortical bone. A full thickness flap was elevated in the oral aspect. A xenograph was used to fill the space between periostal layer and the BCBP. In this case, I used also the fibrin glue to stabilize the graft. The mucosal layer was coronally advanced and sutured to submerge both the graft and the implant. On the photo on the left, you can see the limit of the bone moved buccally and the layer of periosteum. Once we placed the stable graft, remember with fiber glue, I will suture the periosteum to the palatal flap and then make the final GBR suture. You know, you can make the stable suture, mattress, horizontal mattress suture, and then simple suture. Second quadrant was basically treated in the same way, but a sinus lift was performed inside 2.4 and a pterygoid implant inside 2.7. The pterygoid implant has been performed with osteotome and drills just to perforate the lamina. That was very, very, very hard. So the line was cylindric osteotome with active tip until the lamina, drills, conical osteotome until diameter alike. Remember to always under-preparate. Now you know. The rehabilitation and with mucogingival surgery to move the fornix apically and increase keratinized tissue. I generally use more than one provisory teeth, but in this case the human don't want to wait anymore, so finalize the prosthesis before, and is a not perfect, I know, but I think that is a good result. I want to thank you sharing this video that show all the potential of the magnetic mallet. For who wants, I have the final control of the surgery.
That is a very thin crest. The project is to extract a theat 1.2 and placing implant in the side 1.2, 1.5 and 1.7. Extraction of the tooth with the tip of the magnetic mallet. Place the implant bipalatal. And then I need to prepare the site in the 1.5 palatal approach to preserve the buccal bone. Split crest at the working length. And then black ruby to perform the sinus crestal lift. To command the ridge, I use easy pin with the lamina, soft the thin lamina, and then prepare the pterygoid implants with osteotomes, and then I place the implant. This is the final result. And this is the 5-month X-ray control. You can check bone all around the implants and the 1 ear tissue control. Everything worked fine. Now I'd like to thank Dr. Tini, a friend of mine, for the nice photo he gave me, and I hope you like them. Thank you so much. I hope you see you soon. Bye-bye.